Okay, well, in the interests of leaving some time for discussion, I think we will get going. My name is Martin Holt. I'm a professor at the Centre for Social Research and Health at UNSW Sydney, and I'll be chairing this session today, this webinar on the Gay Asian Men's Survey. Firstly, I'd like to acknowledge that wherever you're participating in Australia, you're on Aboriginal land. I'm participating from the Gadigal lands of Eora Nation, and I pay my respects to elders past and present and welcome any First Nations participants who are here today. If you'd like to say where you're participating, you can do so in the chat. We have three speakers and participants today. Limin, an associate professor and one of my colleagues at the Centre for Social Research and Health, who leads the Asian Men's Survey. My cat has now joined in as well, as is tradition, every time I'm online. Tim Wark, who's the Manager of Community Partnerships and Programs at ACON, and Nick Comninos, who's a staff specialist at Western Sydney Sexual Health Centre, and each of them will be presenting some material from the project. If you have any questions or points of clarification as people are speaking and you feel shy about putting your hand up later, please put questions in the chat. I'm sure the speakers will be happy to answer questions when they're not speaking themselves. And it's good to see a bit of discussion as well on what people are interested in. Without further ado, Limin, I might hand over to you. And I note that in terms of timings, Limin was roughly scheduled to have 20 minutes, Tim and Nick 10 each. So I'll keep an eye on that and give you a warning if you exceed 40 minutes in total. Right, thanks.
Thanks, Martin, for being the nicest organizer and the times are. I think, Martin, as Martin said, we will have three speakers, and this time less than like a traditional seminar, we actually trying to make it like a discussion style. So I think today we're going to talk about the New South Wales wide Gay Asian Men Survey, and the data was collected in 2021, sponsored by the Breeze funding. So what I kind of imagine that there's probably three sections we want to talk about. The first part will mainly focus on the clinical bits. The second part, we will kind of broaden to the critical part with social support, language barriers, and health literacy. And the third part is the newest part, kind of hadn't touched in the previous round and was led by my kind of previous PhD student and now Dr. Horace Wong, working at the University of Sydney, who has led the last round of the survey, including the question design with the community. I'm talking about migration, travel, and the transnational ties.
Limin, your slides are not in presentation mode if you were moving through them already.
Right. Is it? Well, I'll let it go through then. Okay. Is that now in presentation mode or presenter mode?
No, it's kind of you're in edit mode at the moment.
Yeah, well, I'll let it go then. Okay. Thanks, Martin. So the questionnaire, we had three versions, Thai, simplified, and traditional Chinese. And this is a list of the questionnaire, the topics that we covered. So this report is already out.
Limin, it's not working at all. I'd probably reshare it because we're not getting anything.
All right.
So yeah, so we can't even follow at the moment.
Okay. And sure. Is that working now?
That's better.
There we go.
Okay, and it's in the full screen now. Okay.
Yeah, and it's on Who Did We Reach?
Yeah, okay. So this is the report. It's out now, and this is our partner ACON actually dedicated. We made a infographics. So here is very, very brief. In kind of 3 months' time, we got over 700 completed responses. Majority, 3/4, is from the Greater Sydney region, and these participants mainly identified as cisgender, as men, and the median age is 30. And this time we actually had less people, from overseas born and more recently arrived. So, but we still got a third people saying that they have lived in Australia less than 5 years. Majority had a university education, but actually almost a quarter had an earning less than 500 per week. This time we also ask about disability. Mainly it's mental health related. And we ask about religious or spiritual beliefs. There's 50%, almost 50, half of them saying there's some religious ties or spiritual beliefs. What we find is Martin did the Sydney Gay Community Periodic Survey, which ran earlier from January to March, which we find that about 20% of people actually had participated both in the broader gay community and this Gay Asian Men survey, but another 80% it hasn't. Okay, when we look at where are the place overseas born, where the place of born, mainly you will expect mainland China. There is a bit from Thailand and Malaysia. Kind of where we particularly targeted Thai people, and about 40% are Australian born. So compared to the previous rounds, which was 2018, we had a lot less overseas born. We had a lot more who have been permanent residents and citizens. But still half of them spoke another language at home, and only half of them, they saying they're fully confident with speaking English among those overseas born only people. And most reported ethnicities as people self-identify as a Chinese, there's Thai, Filipino, Indian, and there's multi-ethnic, each around 10%. So the key clinical findings, as we kind of, as I show you, is 3 points. First, you would expect during COVID, there's reduced HIV and STI screening. The second is in this round, 3 years after the 2018, we see similarly an increased PrEP uptake, but that's affected by language, income, and visa status. We find a lot more substantial PrEP sharing compared to the general gay community. And we probably can touch upon, there's interest about HIV self-testing. So here, it is, among the non-HIV positive people, that 12 months HIV testing has not dropped that much in the way. But what we see is that STI testing, for any STI testing, including all those swabs, has almost kind of fall to half compared to 2018. What we can see is among the non-HIV positive people, 6 months PrEP use has increased to about a third people. So who were less likely to use PrEP? Those who said they had a low confidence in speaking English, they are holding bridging visas, and those had low income, weekly income below 1,500. The sharing of PrEP, which we find quite unique in this Gay Asian Men sample, is among those used PrEP, almost a third said they shared with someone either with or without a script. And when we asked them for the PrEP users, where did they get the PrEP? Apart from the mainstream pharmacy in Australia, actually about a quarter saying from online or from some overseas chemist. So Nick, pass on to you.
Thanks, Limin. Yeah, look, I guess from my perspective as a sexual health doctor at Western Sydney Sexual Health Centre, I mean, there are a couple of the key findings that in this survey that really really reflect our clinical experience at Western Sydney. We see small networks often of overseas born gay men. They may be testing for the first time, or they may be under tested, under screened as per current guidelines and recommendations. We do see PrEP sharing, and so working some of these groups around some of these issues. I have been fortunate enough as an advanced trainee in my sexual health and HIV medicine training to have worked at other inner city clinics in Sydney, so Sydney Sexual Health and RPA Sexual Health. And, I still do sort of feel like for a lot of overseas born gay men, coming from South Asia, coming from East Asia, around Sydney and RPA might be where they work. And so Sydney Sexual Health and RPA Sexual Health will be clinics close to where they work, but Western Sydney Sexual Health is where they live frequently. And so, what we see often reflects that difference and that contrast. And look, I think as well, some points that I wanted to talk about. We do see men that there may be that risk there based on the sexual history. We see men that may come from, say, South Asian backgrounds, and they will come in. They may report sex with transgender women, and sometimes men in these cultures will have sex with sex workers before forming more regular sexual relationships. So they may come with questions around STI risk. They may come with questions around things like sexual dysfunction, erectile dysfunction, and things like that. So I guess there are those interesting cultural elements, but it's those cultural elements that we really have to bear in mind when we're engaging with these communities as well. Another key thing that we see in Western Sydney, and that I feel like I see a lot more here compared to working as a sexual health doctor in the city, are challenges around disclosure. So disclosing HIV status or disclosing, PrEP use to the GP, to their local doctor, if they are linked to a GP. And often Medicare is one of the key barriers there to linking to a GP. But when they are, or they might present, people may present to the hospital-based system, and with hospital care, disclosing tenofovir-based PrEP might be very, very important for their clinical care. Disclosing that they have HIV and that they're on antiretrovirals, very important for their hospital care. And as a doctor, you can see that there is a risk of harm there because there's drug-drug interactions, there's some key clinical considerations. But stigma is that all-pervasive factor that needs to be addressed there by all of us that work in this sector. As a clinician, we support a lot of recently arrived Asian gay men in transitioning, say, from, I guess, more unstructured sexual health and HIV care, where, for example, there may be a risk. They may come in highly anxious. They may be offered PEP or post-exposure prophylaxis, transitioning into, I guess, a little bit more of a planned or structured form of risk reduction, such as PrEP, which generally does involve planning, often involves taking more control. We see a lot of men from these subgroups opting for event-based PrEP. And so we support them with that. My own experience as a doctor, and I think a lot of my colleagues at Western Sydney, our experience is that probably, and I think this is borne out, I think, in local research in this area, among gay men in general, not necessarily Asian gay men, is that those who tend to gravitate toward event-based PrEP or intermittent PrEP probably generally are at lower risk. Less partner numbers in general, but there are some really important exceptions to the rule, and so that's another key consideration there. And look, in terms of partnerships, between sexual health clinics and community, I mean, that remains, incredibly important. Here in Western Sydney around Parramatta, we have a growing middle class, I guess, sociodemographically. We have a lot of different cultures, a lot of, I guess, cultural enclaves, I guess you'd say, similar to perhaps what the inner West was with migrants that have arrived to Australia, 20, 30, 40 years ago. It's happening, and it's happened in the last sort of 10, 20 years in Western Sydney. And with that rising middle class, we have a lot of university educated people. Parramatta is one of the most highly educated kind of demographics in Australia. Lots of people with lots of skills, lots of training. So it's harnessing that for health literacy. It's engaging with community, working with community. One example that Western Sydney has been involved with is providing testing and prevention-based services at a sex on premises venue. So there's a sex on premises venue that falls within our district, and we do regular outreach there. And that's often a chance to really meet and engage those who may not even, men who have sex with men, but they may not identify as gay, they may not identify as bisexual. So harder to reach population groups as well.
Thanks, Nick. Get back to me, or yeah. So now, thanks, Nick, for the clinical part. Now let's move to the broader social support, language barriers. And Nick also mentioned about health literacy. Although you could have university education, but in terms of how to access health, how to access HIV. So here I want to discuss some 5 main issues. One is a connection with both gay and ethnic communities. The suboptimal knowledge about you equals you. Some I want to mention a bit about racism, mental health, and then Dr. Google for information seeking. So in terms of belonging and a sense of community, we find that our gay Asian men feel a lot more strongly belonging to Australia, probably also because this time they are more permanent residents and Australian born and citizens. But they also has some connections with their country of birth. Their close friends are mostly in Australia, mostly from kind of Australian, and also their LGBTIQ plus friends in Australia are most from Australian too. The free time with other gay or LGBTIQ plus friends within the last 6 months, we find 3/4 had almost or some in Australia. So what we find is actually among our sample, about 40%, they had a very close gay connection in Australian. They spent quite a lot of time with other gay friends free time, or most of their friends are gay friends. So in terms of UNU, what we find is it is still not very popular when you have an undetectable viral load and people still finding aversive to the separation that kind of between HIV positive and HIV negative, which in Australia is probably more than 15 or 20 years ago, that history, but still kind of UNU, if they are not HIV positive, still the message is not getting through. So I'm not sure if this can play. Let me just talk about in terms of prepare. So in the prepare study, what we find is over 2/3 saying kind of UNU is accurate, but in the gay Asian men, we had a lot less in terms of believing UNU. So
do you want to try hit play, Limin? See if it works.
Yes, see if it play. So here is a video made by.
出什么事了？我昨天跟人家舌吻了，然后我们交换了唾液，然后我现在很担心得 HIV。交换唾液得 HIV？ 为什么？我跟你讲，我那个在百度贴吧上看到了一个帖子说，HIV 能通过唾液传播。HIV 通过唾液传播？我上次还看到一个帖子说 HIV 通过汗液传播，你觉得这有可能吗？不是，亲爱的，我跟你说，咱们下次看消息啊，还是要通过这些权威官方的网站去看的。好吧，那有什么途径可以呢？像 像什么家庭医师啊、性健康诊所啊，然后还有一个叫 Ending HIV 的中文网站，都可以去查到这些有效的信息的。
All right.
Okay.
Thanks.
So, yeah.
Oh.
So, do you want to stay on that page for a second? So one thing so just to share from ACON, one thing that we obviously work in partnership with Limin to actually recruit for this survey. But one of the things I did want to share is that we actually take this data and put it into action quite quickly. So when we found out that there was less literacy around U equals U and UVL and what that actually meant, the other thing is, like Limin said earlier, Dr. Google, we also found out that many participants actually get their information not from credible sources. So for us, it was very much about going, okay, well, a huge proportion of this survey is done by those from a Chinese background. We actually need to think about doing some campaigns that focus on the really basic understandings of HIV and look more like the campaigns we would have done 5 years ago. So when we actually spoke to community, some of the questions that they were getting were things like, can I get HIV from deep kissing? Now that seems to me, as someone who's worked in this space for 7 years, a question I would have heard 7 years ago as opposed to now. So what we're looking at is actually doing in-language videos that are written in language from the beginning. They're not translated and they're written by and for communities. So this video in particular was written by 2 of our Chinese workers within ACON in collaboration with community. And it's really going back to basics, looking at, can we actually get HIV from deep kissing? No. And then, well, where do I actually get credible information around HIV? Now, the other thing we wanted to make sure was that we literally replicated the process that you would go through as a peer, right? So if you're worried, you call a friend. To that friend, you say, hey, I'm really worried about this. Your friend kind of goes, you're being ridiculous. Go to this website. This will make sense. So I just wanted to really flag here that this is how we're actually using this data in real time at ACON and creating kind of small campaigns that directly respond to what we're seeing. Back to you, Limin.
Thanks, Tim. So the racism thing, we want to talk about, in terms of experience of race-based rejection, discrimination with 12 months. So you can see that I've listed the rank. You expect, kind of a lot of from white gay men, then the general Australian society, 61% from white gay men, then, general Australian community, other gay men of non-white, non-Asian background, and also gay men of Asian background, that's around 50%. The lowest, good is from healthcare workers, but still there is up to a third saying that they had experienced them in the last 12 months. So what I gave you a summary is, kind of racism, what we find is mostly impacting mental health as a gay response. Tell us if they had any experience of those race-based discrimination, rejection in the last 12 months, is actually 91%. That most of people had that. And up to half, they had 4 types, more than 4 types of, from different groups. So that is a kind of a glaring thing that's saying that racism is quite rampant in the community. And what we find is, in terms of what we did a K6, very quick one is, a quarter of them saying that they're at risk of a serious mental distress. So who are more likely to have those serious mental distress? They had experienced some domestic violence, earning, almost under poverty line, and have no connection with our LGBTIQ+ society in Australia. So in terms of, Dr. Google, Tim also said, this ACON specific video, what we find is still Dr. Google is a, is the most prominent one. What we find improving is, if you have only one channel, that's more likely, if it's not credible. But if you have more than channels, things are getting better. Particularly here, when we see LGBTIQ plus events, the Mardi Gras Fair Day, ACON, about a quarter of people actually had, posted in clinics, hospitals, English-speaking healthcare professionals. So those are really credible sources. One missing is among English-speaking health professionals here, probably. So while we quickly move to, before Martin kind of signed a bell, the migration and the mobility. And here it's the first time, it's Horace's passion to really look at, even from his PhD time, looking at these transnational times. What we are trying to say is, yes, in New South Wales, or in Australia, we are interested in their sexual networks, communication, and all that. But also people, they also have connections in the region, in their country of birth, with other people. So it's, and also kind of there's a lot, before COVID and even during COVID, there's quite a lot of traveling going on. So the transnational kind of ties with partners, from, overseas and all that, what we find is, before COVID, there's about 70%, they said, last time had sex outside Australia. There's time before COVID, but even during COVID, during COVID, still there is people, they do overseas travels. And the three top destinations, not unsurprisingly, apart from China, they are Thailand and North America. And there are times, still, had condom with or without PrEP when you had overseas sex, but also there is kind of the risk when you in a different environment. So here I would like to pass on to my two esteemed colleagues to talk a bit, from both from the clinical side and from the social side about transnational. Nick, first, please.
Thanks, Limin. Yeah, look, I think, from my perspective as a sexual health doctor, the transnational elements are always really, important to bear in mind. I guess, purely from a clinical perspective, we do see what we call AMR, or antimicrobial resistance in bacterial and viral sexually transmitted infections, often coming from the Asia Pacific region, and that's at our doorstep in Australia, where there's the ever-present threat of multi-drug resistant gonorrhea, gram-negatives like E. coli and Shigella, which can be sexually transmitted. We see a diversity in HIV genotypes in Western Sydney among those newly diagnosed. So, that's one, I guess, aspect of thinking, I guess, transnationally, from a clinician's perspective. And then there's the pervasive importance of stigma as a factor in engaging with the healthcare system. So as Limin and Tim, as you've mentioned, that U equals U messaging, really is key there. And the experiences of many men, in their home countries, or in some instances countries they may have lived in throughout their life before coming here. We need to remember that for many, they may have lived in several countries in the region before arriving in Australia, not just their country of birth. So there's immigration stress, there's minority stress, as we've touched on. There's sexual racism, there's job security, there's a range of other vulnerabilities there. As a clinician, we need to be thinking about the impact of those factors on sexual risk-taking, on transactional sex in some cases, on the risk of exploitation. I think those are those are at the forefront of our minds as sexual health clinicians as well. I think there's been the impact of COVID, as we've touched on, and I think a lot of today's discussion points and the findings from the survey. COVID is obviously the elephant in the room. And the pandemic and what's been happening in the last couple of years there. I think also for those at the coalface providing sexual health and HIV care, you know, we need to bear in mind that, you know, Asia is a very broad area, isn't it? And that's really reflected in the demographics of Western Sydney. It's language, but it's not just language. You know, there are different cultures and, you know, different religions. You know, in a very small, I guess, geographic area compared to the geographic areas that we're used to in Australia, whereby, you know, you've got, you know, Indonesia, and then you've got Malaysia, and then you've got South Asia, you know, Southeast Asia, South Asian countries. So, and you know, the diversity of things like religion, you know, incredibly important to bear in mind when engaging with these communities. And then, you know, I guess the other point that sorry, I'm about to sneeze. The other point that I'd make is, you know, the vital importance that we see here in the clinic of social workers and counsellors, and having a social work and counselling service to help people navigate the complexities around, you know, sexual health, healthcare seeking, in some cases new diagnosis of HIV, when they've arrived in Australia, and there are all of those adjustment challenges, and there's you know, a lot of stress around migration and the migration process. So, you know, counselling and social work teams are, you know, invaluable there in keeping these communities engaged and working alongside these communities, individuals, small networks, in supporting adherence to PrEP, in supporting, you know, regular attendance for screening, adherence to HIV, antiretroviral therapy, a whole range of other measures there as well.
On to me, Limin, do you want to click the next slide for me? Yeah. So I thought I'd use this as an example that, as Nick was just saying, Western Sydney is incredibly diverse. But one thing I do want to flag with that is that diversity also means we actually have to have campaigns and health messaging that targets those incredibly diverse communities, and to ensure that that messaging is actually made with those communities. So earlier you saw that video, which was actually made by community for community. Now here's another campaign that we did with Southwestern Sydney Local Health District. We also did pop-up testing. Now we did this campaign as part of an event called Westball. Now Westball is a huge kind of party that happened at Casula Powerhouse. There was over 500 attendees. Now, the vast majority of those attendees were actually people of colour, LGBTQ, and very, very diverse. So what we actually did was work with the organisers, so the Westball itself, and work with them to actually create a campaign that specifically was made up of the performers that were there at Westball, but also made sure the campaign looked like the people attending the event and wasn't limited to, say, just gay men. Instead, we looked at a campaign that targeted everyone within those broader communities. So whether that's trans women, gay men, queer people, kind of everyone. Now, one thing I do want to mention about this is this was incredibly well received within this target community because they actually got to see themselves and read themselves into our diverse campaign for the first time. Now, as you can see, we actually only used people of colour. And one of the things with this, and I think I'll talk to it in a minute, but it's also recognising that when we as a collective sector have thought of, say, the gay community, we've often imagined that to be a very specific community within the inner city. But as Limin actually mentioned in her data, a lot of people are connected to communities, but those communities aren't necessarily the imagined gay community that we always target. Instead, they can be like this community, which is much broader, and you have our target audience within this community, but it's made up of the broad LGBTQ spectrum. So this was an example where we actually co-designed, and this campaign, again, was by community for community. And I really think that that is the way forward in terms of looking at campaigns that target specific areas and specific cultural backgrounds. We'll move on. Yeah. Oh, Oh, so thanks, Lena. So I do think moving forward, there needs to be renewed focus on Western Sydney. I know there's an A-test scoping happening. I don't have much to say on that. Martin or someone can speak more to that. I don't need to. So the other thing I want to flag is there's often, we would speak about HIV as in a city, which is made up of over 20% of gay men within a certain set of postcodes. Then we'd go, the rest of the diagnosis happen outside of Sydney. And then we kind of imagine as though as that is all of New South Wales. But in reality, 90% of those diagnoses are happening in Western Sydney. And this is why we really need to renew that focus on Western Sydney, but also actually have a broader look at things like racism. So within our strategy, we look at things like stigma. I'm sorry, I've got to stop reading the chat while I talk. We look at broader things like stigma, but I think all of us in health have learned we actually also have to look at things like racism and the role, the impact that actually has on health access, on things like feeling comfortable with your gender or with your sexuality. And that's, for us at ACON, that is something we're really focused on these days is, well, what are the other health factors that are actually going to get in the way of what we want to achieve around eliminating the transmission of HIV? Okay. I don't have a lot to say here other than World Pride is coming and all of us in the sector are going to have to really ramp up testing, ramp up our engagements, but we kind of all know that. So I want to finish on this section here of really looking at a paradigm shift within our actual response to HIV. And what I mean by that is looking at the ways in which we work with culturally and linguistically diverse and overseas born communities, and how we actually shift the cultures within LGBTQ and HIV organizations so that people who are also affected by HIV, who are either cold or overseas born, actually see themselves in the organizations, want to work there, and that our strategic responses are actually made up of their lived experience. So at ACON, we're actively doing that by, we created a multicultural engagement plan, but a big part of that is literally shifting the organizational culture of ACON so that people will actually work at ACON, which means that in every level of our response around HIV, we actually have that lived experience. We're fortunate that we're a community controlled organization, but we need that at every single level to really, I guess, respond effectively. And this is something that if you see me present these days, I bang on about it all the time, but ultimately I would argue this is the answer to our divergent epidemic. Okay, I think that's everything from me, Limin. Yes.
Thanks, Tim. You know, it's always great, 20 years ago, I want to say that, probably was starting from Garrett Prestage, that, and kind of from the National Centre that led me into this work. We are probably the only team that interested. But now here's the ad from Jason Ong's group that there is a crowdsourcing for Asian-born gay men that, looking at how to increase the uptake of PrEP. That's the ad for some design ideas. Then Lisa just left from WA. The Curtin University also recently completed ARC looking at BBD-STI surveillance among COD communities. So more and more, kind of passionate academics, community kind of leaders, and peers and from the community themselves are joining the force, trying to look at HIV, STI. Sexual health, but also broader issues, intersection with, culture, linguistic, but also in terms of, mental well-being, in terms of racism, in terms of, kind of human rights-based issues, also about equity to access health information services, and the kind of, service we design. So, Martin, we are quite good, have 20 minutes. And before I get pass the baton to Martin for questions. I haven't been monitoring. I just want to thank my director, Professor Carla Law, that, recently she had some family issues, but, really she's a strong advocate for the work and believe in, what we can do for the gay Asian men kind of space. Thanks. Martin?
Thank you. Thanks, everyone, for your contributions. We have, and you've run very well to time, so we actually have plenty of time for questions or comments. So does anybody want to make an initial comment or response? You can put your hand up, or you can just unmute and speak up. Or if you're feeling shy, you can put it in the chat and I will read it out for you as well. I'm just looking.
I'm not shy. Can you hear me?
Yes, go for it.
Okay.
Hi,
thank you. Hi, everyone, and thank you, Limin, Nick, and Team Wark for the presentation. It's very encouraging to hear this data and these numbers, particularly the parts about how, as a community overall, we are affected by racism to this extent. Recently, our sector has been going through a review for the national HIV strategy that's upcoming. It is a 7-year strategy, but the R word, the racism word, was mentioned 0 times in the 35-page national strategy that was meant to go for 7 years. Firstly, I want to know how you all feel about this, but and secondly, I would like to know, like, as long-term researchers who's contributed so much in this space, do you think there's a need for the HIV sector in Australia to really, look at racism as what it is, rather than keep putting us under the name of culturally and linguistically diverse people? So that's my question. Thank you.
I'll probably start, Justin, and I'm happy to hear what other people think. So I know Justin from many years, since your UNSW time, right? And I know you're an advocate. I think to address the question is, I think in our center, what we believe is, the human rights-based approach is a fundamental to everything, including the health rights, some of my colleagues and some of my friends know recently I joined the City of Sydney as a multicultural advisory member to them, because I think racism, under, multicultural, kind of racism is definitely something very, kind of attached to this multicultural thing. And what we can see from the data, at least, Horace, first time we blatantly asked about racism. Previously, I was, hush hush, and Horace listed all the groups that. What we can see is, there is some expectation about racism, but also I want to draw the data to say there is this more fundamental internalized stigma that, racism from our own gay Asian men, our own community Asian society. So I think, yes, there's a lot of layers, but, to directly answer your question is, in our center, we social researchers looking into health, but we think human rights-based approach, and in this case, called racism, is directly something we need to head on to. Thanks. Tim and Nick.
Oh, and Tim and Nick, if you want to respond, please do so. We also have another question from Rex as well. And Justin, I'll just say, for those of us who can see the national strategy, these are really good comments, because we have time to shape what goes in the strategy, I think.
So I obviously love this question. I think it's really important. I also think that on that question, Justin, I noticed that within the latest strategy as well and gave that feedback. I also think it's interesting because we hosted the political declaration on HIV and AIDS recently. Australia was the host country, and within that document, they actually talk about the effects of racial discrimination. But despite us hosting it, that hasn't carried over to the new strategy. So there are a number of people like myself who is pointing out, look, we actually have to include that in the strategy. I also think that given the data and that we have a divergent epidemic, it's a huge barrier. that we actually have to find a way to focus on race, racism, ethnicity, so that we can really have more tailored approaches. I say this point, I say in every one of these, so we need to be able to talk about culture, language, and ethnicity, and actually like pull apart that data so we know whether the Australian-born people being diagnosed with HIV, what is their cultural background? And like Ben Babington always says, do we have a cultural epidemic, an epidemic based on culture within Australian-born? We don't know. So there's actually a lot of gaps in how we talk about these three factors that I think as a sector, we really have to come together and find that out. A great example is cold and overseas born is used interchangeably. You can clearly see that I'm not white, but within our data, you just can't capture my experience. And there's many people like me. So I think it infuriates me. I worked in this sector for a while, but I would say we are starting to make grounds here. I also think that at the end of the year, we'll have a national framework, anti-racism framework released by the Human Rights Commission. I think that will be really useful in actually pushing for change within our sector. Victoria is also working on their own. And within that, ACON's also been pushing to actually include racism as a barrier and a kind of factor in worse health outcomes. I think I'll leave it at that.
Thanks, Tim. Nick, I might move on to the next question from Rex, if that's okay. Rex.
Hello, thanks, Martin. Hi, everyone. My name is Rex. I'm the project officer for ACON's Asian Gay Bi-Plus Queer Men's project. So I just have a comment because I have been an international student for 10 years before I landed on this role at the beginning of this year. And in the last 8 months, two of my biggest challenges in my work, the first one is how to culturally contextualize the health messages, because I have talked to community members about U equals U, and some of the feedbacks like undetectable. The focus is more it's hidden. Something is hidden instead of untransmittable. And also in many countries, there is no sexual health clinic. And the second challenge is how can we reach out to especially younger community members who are more socially isolated and who are not affiliated with any school body or queer collectives. And my comment is my comment is like this proposal that we need to consider is more of a strength-based approach as the lens when we are designing our health messages and campaigns. And I think this strength is culture. Because culture mediates our experience of our sexuality and sexual health. First of all, like, especially as new migrants or international students, the first thing we experience is disengagement from our culture due to, like Nick mentioned before, the immigrant stress, minority stress, and the encounters of racism, which leads to poor mental health outcomes and also internalized racism. And the other thing we notice in the community is that how the community, Asian community is divided. Like, Chinese are only hanging out with Chinese. South Asian community members are only hanging out with South Asian community members. It's almost like they are like in silos. They are divided. And so what I've been trying to work on is how we can use culture as a glue to build a solidarity in the Asian community, because Asian community and cultures are not homogeneous. And it's important to build cross-cultural space during cultural days of significance. Therefore, that way we can more effectively engage communities, especially with ones who are more socially isolated. So one thing I've done recently is the Mooncake Festival. This festival is traditionally a Chinese festival. By my project, we designed a celebration that invites community members from South Asian and Southeast Asian backgrounds to join this celebration. And on this celebration, we talk about, we're having these cross-cultural conversations, and we're also sharing our experience with sexual health, try to put in some sexual health message. And the feedback, the engagement was very, very positive. So I think it's important to acknowledge and celebrate the diversity in Asian culture and communities.
Thanks, Rex. I think it's actually a really interesting comment and something we completely forget, that Asian as a category only makes sense in Australia when you're combining so many countries in the region. If you think about it, it's completely mad treating it as a homogenous group, a bit like what Tim was saying about CALD. Tim, can I just give Danny the opportunity to ask his question or comment as well, and then you can respond to both comments.
Oh, thanks, Martin. My name is Danny. I'm speaking from NAPWA, the National Association of People with HIV/AIDS. And I guess I was just thinking in terms of HIV prevention and surveillance, or HIV and STI prevention and surveillance. I feel that it can be quite difficult to be truly inclusive in terms of language and the scope of research and scope of policy and advocacy and knowledge as well. We know that language around that space can be very diverse and contested, and we know that there is terms like POC, there's BIPOC, there's CALD, migrants, transnational, people born overseas, people who speak English as a second language, people from diverse backgrounds, transnational, multicultural. I'm not sure if there's anything I've missed, but some of them were rooted from the white Australian policy, which has since been abolished, and some are from international discourses, and ultimately each of them intersects with different needs. And so I guess I was just thinking, how do researchers, policymakers, researchers, professionals in the sector decide what language to use, or which of those population groups to prioritize? It's a difficult work that you are doing. Great work, congratulations. But how do you navigate which one to prioritize? And thank you.
Thanks, Danny. Does anyone on the panel want to respond?
I do the difficult one, Danny. I acknowledge, as Martin said, it's a kind of lot of acronyms and terms. I think that yes, in terms of intersectionality, it's not a simple solution. Why we created a lot of terms, and sometimes those terms can even stigmatizing themselves. What as a researcher I saw 20 years ago, and I still believe it, I never thought that the research is without limitations or weaknesses. There is always things, what decides our agenda from different perspectives. For example, in terms of HIV and STI particularly focusing, we look at the data from surveillance, we talk to the community, we try to address probably in a less proactive but more reactive way is who should be prioritized. But now more and more from our social research perspective, the co-design with the community, not just trying to problemize the problem, but working with them to identify the issue and solve the issue is probably the way we're going to approach. So I'm less, yes, I take all those criticism, and as Martin knows, 20 years ago for my first presentation, they said, well, who are the gay Asian men? You just coined that. There's a lot of problems with that itself too, and it could be stigmatizing. But for our researchers, recognizing the limitations, but if we decide that we work with the community and we know we can have impact, then I'm willing to bear all those criticism, but also trying to carve the way to actually chip from different angles. Carla and the team Brody's research, they had a stigma indicator. We borrow from them. A lot of questions from the gay community periodic survey, Martin and the Ben leading. We try to borrow some questions, but we also create our own question as team. And Nick and Horace knows that, we create, it's not ACON, it's just our recruiting partner. We actually work with you to co-design some questions, right? So I'll just say that.
I'll build on that a little bit. So I think that terms in our communities will always be contested, full stop, and that's okay. I think when we are talking to community, we actually just ask them what terms they want. But I do think we need a data standard around how we collect culture, ethnicity, and language within the HIV sector so we can actually compare that data across all the work that we do. Now, FECA is looking at that standard around culture when it comes to the ABS, because they don't even have a standard, and how we collect anything around culture within Australia is not done well. So for me, I definitely think we need that if we actually want to get down into what Rex was speaking about, which is actually targeting culture and cultural understandings of health, well-being, and community as the kind of glue to reach out and connect to people. I think that's really needed. And I think the way to do that is co-design. So of the two campaigns I shared earlier, they were targeted to very specific communities. And I really think that's the way forward.
Thanks, Tim. As someone who runs one of the BMOF surveys, I welcome all suggestions for standards as long as they're incredibly short and can fit on 3 lines in the questionnaire. So good luck with that. Like, we're on a bit of a journey and trying to accommodate all kinds of things. Can I take you back to, I was just thinking some of the participants may not realize, it was striking to me looking at some of the data that there's something that stands out about participants in the survey, that they actually report higher levels of condom use and PrEP use than other gay and bisexual men, which I think is a bit forgotten, like sometimes. So actually as a group, and notwithstanding how we've lumped all these people in together, as a group, there's actually high levels of protection. And yet we know from the epidemiology that some Asian men, generally overseas born, remain at higher risk. And so I'm thinking about some of Nick's comments about, like, there's something in the data here that suggests there is opportunity to build capacity and make people safe, but some people fall through the cracks. And I'm just wondering if, based on the data you've collected, of the many things you've raised, which you think are the most critical to tackle, whether it's kind of protecting people against racism or giving them easier pathways to access services and so on. We have 2 minutes left, so just solve that in 2 minutes for us.
Yeah, Martin, quickly, use the segmentation. I think you're spot on. And Ben also noticed before, what we see here, and Curtis is also analyzing the data, there's actually 2 groups. One group, they are worried well, they are very much, about 20% of people, they may have very high risk, but well connected to the gay community, take, access to, lots of things. Kind of that this is a group, but there is also the group with a lot of intersectionality, probably kind of vulnerability in a lot of ways, that they are not connected, isolated, and probably, their only way not, is Dr. Google or something. So it's not a congruent group. What we think is actually ACON, and also nationally Australian, I know Stuart is here, that, with Asian men, we are trying to promote these peers, using those peer leaders, try to kind of percolate to those less connected in the way that, and for our researchers, it's still very, very difficult to connect to those, even, if they answer our questions, right? So, like ATES and all that, you have the service, you have different service modes, different, kind of for them to access a point, but still that's a question, for us to continue to work on.
Right,
just to sort of add to what Limin said, Martin, I think, testing is a crucial, piece of the puzzle as well. With, with HIV, we've seen this pattern of, no real change in the proportion of diagnosis of HIV with advanced disease. which is a giveaway, isn't it? That we're missing opportunities to test those at risk. So, just to add to what you said about falling through the cracks, and we know that there's been potential for transmission there as well when there's not been earlier engagement with care, taking those opportunities for testing as healthcare providers as well.
I mean, you're collectively showing a really amazing partnership in action about being able to use this data to differentiate response, which is amazing. Now, I'm conscious for those of you who have other commitments, time is up. This was a great session to take part in. Thank you for letting me chair it. Thanks to all of the speakers and the participants for your questions. If you didn't get a chance to ask a question, I'm sure Limin, Tim and Nick would be very happy for you to contact them and take that up with them later. And I think we'll all be looking forward to future data from the project as well as your collaborative activities. Thanks everyone for joining us, and we look forward to seeing you again in one of our webinars. Have a great afternoon.